Good morning. My name's Kevin Reynard. I'm the medical director with ESIST, and we're pleased to be hosting a series of webinars around optimising timely discharge. This webinar, as I said, will be recorded and will be going on the ESIST YouTube channel later on today. In terms of how we'll manage the webinar, this is being run as an in conversation with type webinar with Bharath and Ben, who I'll ask them to introduce themselves in a minute. If you have questions that you'd like to pose to them, please put them in the chat. I will be monitoring the chat and will ask those questions to them. I may have to merge some of the questions together to make sure that we get through all of them, and I hope I still convey the meaning of the questions you're asking. If not, please do put that down in the chat and we'll try and cover it again. So if we can start off just by asking Ben and Bharath to introduce themselves, and then we'll get going. So Ben.
Morning, my name is Ben Owens. I am an ED consultant at Sherwood Forest Hospitals in Mansfield, and I'm a clinical associate with ESIST.
Morning everybody, I'm Dr. Bharath Lakkappa. I'm a consultant geriatrician and a clinical director in adult services in Northamptonshire. I also mainly, I've been a clinical associate with ESIST for a few years now.
Okay, thanks very much. So as I said, please do post your questions in the meeting chat. But let's start off just by asking you, so what do we mean by risk? Yeah, who has the risk? What risk do people feel? Yeah, just define the area that you want us to be talking about over the next hour. So, do you want to start with that, Bharath?
Yeah, thanks, Kevin. I think people, if you look at most of, it's a national illness service or national health service, whichever you call it that way. If you're looking at 80% of our resources spent on 20% of the frail and elderly patients who usually contribute to quite a bit of risk in patient care. The difficulty we face is there's three aspects which we know of: is pre-hospital care, hospital care, and then the bit which we all forget is nearly most of the time is spent in pre-hospital care, which is at their own home. And nobody asks the patients what risk they're taking, how they're going about their daily life. And then the minute they hit the front door or they come to our wards, we seem to be taking over control of all their aspects of life. So as a conversation, I'll bring Ben in, because when we have a conversation about people having kind of elective surgery, we give them a list of what happens. But when we take a patient in who's non-emergency or emergency admission, we don't discuss the same risk as what happens in the hospital. We might have surgery, which is really clear cut of what you're going to do, but similarly to that, the patient also is coming into hospital for some things to be done. If nothing needs to be done, or no IV antibiotics or no IV fluids, how do we explain the risk of them staying in the hospital, which then the patient can take their own kind of decision-making aspects into the risk they can actually be able to live with. Ben, I think when you talk about the other bit of risk in A&E, that'll be helpful as well.
Yeah, thanks, Bharath. And I think you're right, and it's trying to strike a balance here. And at times we talk about what is safe and not safe, and I think the challenge back is I don't think there is such a thing as safe. Whatever we do, there is a risk in whatever we do. So it's talking about there's a risk of going home, particularly for frail elderly people, but there's a risk of coming to hospital, particularly for frail elderly people. We know when people come into hospital, there is deconditioning occurs from the second you're in hospital, because you're less mobile than you are at home, except for a tiny number of patients. We know for less mobile, we lose weight. We know people with hospital food will tend not to eat as much, will tend to lose weight, and therefore lose muscle mass, and therefore lose independence. There's a confidence thing sometimes for elderly people, but there's those risks of nosocomial infection and other things, and as well, which are less likely in their own home. There is, of course, the falls risk in hospital, and Bharath will talk about that in a minute, actually goes up, not down, because they're in a strange environment. If you fall in hospital, we've got concrete floors. If you hit a concrete floor, you're more likely to fracture your hip than if you are in your own home. So it's looking at, there is no thing as safe, there's no safe decision, but there's a low risk, middle risk, high risk, but actually that risk is really the patient's, and the patient in elective care, as Bharath says, the patient is allowed to choose to have a bypass or not have a bypass, even if not having a bypass could mean their life is shortened, but actually the risk of the anaesthetic might be greater, or they may not want to do that, or plenty of other operations we talk about, and we give them that choice. When we come to hospital admission, we're not very good at it. We tend to say, I'm worried you're going to fall, I'm worried you're going to get sicker, I'm going to bring you in. And actually, sometimes it's about what matters to me, what matters to the patient, asking them their opinion rather than what is the matter with me. And actually considering alternative submission and actually allowing a frail old person to go, do you know what? I've been a falls risk for the past 10 years. That hasn't really changed. So why would I go into hospital now? Could I try all antibiotics and come back if there's a problem? I'm really worried about leaving my house or whatever else. So actually it's about talking to the patient and talking about that risk to them. I think caught up in a lot of that is what the clinicians worry about, and the risk, the perceived risk to them if something goes wrong, and that's part of what drives our behaviour to do this is around that.
So you've talked about the risk that we see in elective care, and we're often able to explain that quite clearly to patients because we've got really good data to quantify that risk. How do you communicate the risk where we don't really maybe have as accurate numbers about the risk for patients when you're having conversations with patients and their carers?
Kevin, the data is quite clear. I mean, the range might be a bit different, that's all. Like exactly what Ben said is, if you get a 65-year-old who is at home, the risk of falls is around about 36% in the future. But the minute the same person you admit to the hospital, his risk goes up to 50%. But the difficulty is, even though you fall in the community, you have a risk of around about 1% being hip fractures. But the minute you hit the wards and they have a fall, it's 50% of them will be hip, spine, or skull fractures. I mean, there's quite a few detailed kind of statistics available, but the difficulty is how do you explain it to them? The other thing is, if you look at the risk of malnutrition, it's actually highest in acute hospital compared to a residential home and then at home. So if the patient is not eating and drinking, acute hospital might not be the right place. Putting them in the community, and if you can't provide the services, then that's a different matter, that an MDT decision has been made. Similarly, if you say that if the patient is about 65 or 85, the risk of delirium goes up. So if you're 85, it's a 1 in 5 chance of delirium going up, because we know that there is neurodegenerative conditions present in them, or they've not been diagnosed, like cognitive, Parkinson's, or any other issues going on. So we do know that risk of delirium going up, the increased risk of delirium means that they've got increased risk of, again, falls, increased risk of mortality, increased risk of nursing home placement. If the patient comes in specifically that they've got a chest infection where the curb score is 2+, which means the mortality is higher at home compared to hospital, we give them IV antibiotics, treat them, and then we send them home. But if the curb score is normal, you're not giving them IV antibiotics and IV fluids, then explaining to them the possibility that their risks are that they have these different falls risk, iatrogenic infection risk, delirium risk, length of stay goes up, deconditioning goes up. The other interesting thing is, as we all know right now, without enough support from social care, but imagine even if you do have support from social care, which is 100%, if a patient stays for more than 7 to 14 days due to the deconditioning, the increase in the package of care or the support for the ADLs goes up as well. So somebody who's independent, nearly 1/3 of them might need some help going out of the hospital, just because we know that most of the time what people do in the hospital is nearly 95% of the time they spend their time horizontal or sitting down. They do not move in the hospital, so the risk of deconditioning is quite high. If they do not know the place, they also don't take the risk of going and walking to the toilet, so it might come out as confusion and delirium. So is very similar to a pre-op or post-op setting. And if you look at all the data and if you explain to them that these are the risks of an admission when it's not necessary, these are the risks when the patient's family says if they'll fall, they're going to fall more in a hospital compared to when they're going to fall at home. So how do we explain it to them, and taking ownership of the risk is important. The risk still lies exactly what we said is with the patient. If they do have mental capacity, then as we explain to them about other things, I think it's only fair that we give them a chance. They've managed to live for 85, 90 years at home without anybody disturbing them and them taking the risk, and we explaining to them might be a good thing for us to do just to make sure that they're independent for a bit longer. I just took too much of your time, Ben, if you want to come back on that one.
No, not at all. I think that the thing here is around, it's hard to quantify, but it's about giving people as much information as we can. We don't, when any individual operation goes, any individual patient, sorry, goes for an operation or procedure, we know the rough risks. We don't know the risk to that patient. So we don't know if someone goes for a hip replacement or a bypass or a bowel resection, there's a risk that is a generalized risk within the population. We don't know the individual risk for that patient particularly, because every patient is different. So we never know the true stats, exact risk to a patient, because we go on generalism. So I don't think we need to know the exact figures, but we can say the risk will go up for the following things. Being in hospital, it's about an honest conversation, and I do it in ED a lot. So there are people who are clearly very poorly, and we're not saying that hospitals are bad for you if you're really poorly. They're clearly very good for you. None of us would be doing the jobs we do if that was the case. It's that, and a good way of thinking about hospitalization is it's a bit like a drug. If you don't need the drug and there are side effects to that drug, then actually you wouldn't take it. So why would you go into hospital if there's an alternative drug, or I don't want to imagine that thing. And if you do need that drug and you come into hospital, think of it like a dose dependent thing. The longer you're on an antibiotic, the benefit of the antibiotic goes down and down and down, but the risks of C. diff and antibiotic resistance go up and up and up and up. So there's a point when hospitalization is probably riskier than not. And it'll be hard to define that exactly. But our job is to talk to the patient. And the way the elective care analogy is, we're negligent in elective care if we don't discuss the risks. And if we do discuss the risks and the patient makes a decision one way or another and something goes wrong, medically, legally, we're completely covered because we've discussed them and we've documented it. We've done the right thing for the patient by doing it. In emergency care, we rarely discuss, we talk about the risks of going home. We don't talk about the risks of coming in. So actually, how can it be we're negligent in elective care by not, if we don't discuss them and document it, but in emergency care, we don't discuss this at all. Actually, we're not giving the patient that choice. And I think one of the issues here is if a patient is discharged from ED or is discharged from a ward and gets readmitted, the language we use, we talk about failed discharge. If they go home from ED and they fall, or they come back more unwell, we go, this patient, that is attributable. We go and do an RCA. If someone falls on a ward, it's a serious incident. The way we look at things that can be attributable to apparently attributable to one person, we really investigate. If someone comes into hospital and they deteriorate, come into hospital with a UTI, get better, then get hospital-acquired pneumonia, then die, we don't investigate that as an RCA. Was there an opportunity to discharge this patient? We just go, they died in hospital. We don't look at that part of it. So it's about looking at there are risks in everything we do, and how we do it. And someone's put something in the chat to pick up around whose risk is it, and people often, we talk about this stuff to clinicians, they will talk around, well, the coroner, they talk about being sued, they talk about complaints from relatives or complaints from a patient. If something goes wrong, I'll get a complaint. And so if we look at the patient risks, loss of independence, potential becoming severely ill, potentially a very small number of people in the hospital die because they're in hospital from non-scomal infection or other things like that, or just actually having, if you're in your last 1,000 days of life, less time at home with your family, particularly at the moment, relatives and things around. What does the clinician risk? Well, coroner's cases, I work in a hospital that sees 160,000 urgent care attendances. As a hospital, we have 10 to 20 coroner's cases a year. So what's the odds of your decision ending up in a coroner's court thing? Pretty low. Of those coroner's cases, how many are result in the clinician being heavily criticised? It's maybe one a year. So 160,000 down to 30,000 admissions. Risk of being sued if you work within a hospital, particularly, you're covered by the hospital. To sue a hospital clinician individually, you've got to be so far outside the normal decision making. A complaint, well, complaints may happen, but most complaints are resolved when you talk about it. And as someone who discharges a lot of people from ED on a sort of risk balance basis, perhaps more than some, I'm yet to have a complaint about it because I make sure I have a conversation with the relatives about and the patient about why we're making that decision. So the worst that's happened to you is in reality is you might get a complaint. The patient risks so much more, and actually elective care, we accept that. So and that's the thing. So it's someone like, why does the risk sit? I would say 99% of the risk sits with the patient. We will go on with our lives. You might get a bit of stress for complaint or whatever else, but the grand scheme of things, and it's in elective care, we just accept that.
So within healthcare generally, I think we've developed a culture of trying to make things as safe as possible. You've alluded to the fact that there's no such thing as a safe discharge, but we have an industry about trying to make discharge as safe as possible. Do you think that the culture within the whole of this process impacts on our approach to this, and how, if you do, how do we swing that to move things into a more realistic perception of the risks?
I think the best example of how our culture drives behaviour that probably increases risk to patients or doesn't manage it well at all is the neck of femur analogy. So if someone comes into hospital, so people have falls risks is a common thing in hospital. They come in with an illness, they do need to be in hospital, they're going to be discharged, they're unsteady on their feet. So someone who comes into hospital with a UTI, who's unsteady on their feet, who's old and frail, who hasn't fallen. They haven't fallen yet, they come into hospital, they are a bit unsteady, they're wobbly in their own home, they might cruise around the furniture holding onto things. They can't do that in hospital because you've got big wide open spaces across wards. They're not going to do that. They're often treated as a falls risk. They're kept mostly in their bed or in their chair or taken to the toilet with someone rather than being allowed to go to the toilet on their own, so they're likely to lose a bit of muscle mass and independence. If after a week in hospital they fall and they break their hip, they're hopefully operated on the next day. Day one post-op, we mobilise them every single day. So if they come into hospital having not fallen, being a bit unsteady on their feet, we keep them mostly sedentary. The second they've broken their hip, we mobilise them every single day, even though if they're a higher falls risk because they're deconditioned and they've fallen already, they've got metalwork in their hip and a wound in their leg, they do fall and they do refracture. That's a really difficult thing. So the risk of falling has gone up, and now we mobilise every day. And the really daft thing about this is if they fall in hospital after a week and they don't break their hip, they're deemed to be a higher falls risk and are mobilised even less. So if you fall and break your hip, you could argue you'll be more mobilised and more chance of getting out of hospital than if you fall and don't break your hip. And that's about our culture and how we see risk and falls within the system. So I think, how do you change that? You've got to look at the balance of risks, and there's a tool which is used a lot now called BRAN, which is what are the benefits, what are the risks, what are the alternatives, what if we do nothing? And it makes you think about the risk. Staying in bed will reduce their falls risk temporarily, but they'll decondition, their falls risk will go up. And Bath's giving us this out sort of already. What are the alternatives? We can mobilise them daily anyway, regardless of what if we do nothing? Well, they're going to decondition further. What are the alternatives? They could potentially be discharged, and that is their choice. So it makes you think. We see big risks in front of us and we don't always consider alternatives, and actually that comes from elective care, but it's to try and make you think differently and an honest conversation with the patient, I think, about what they want.
I think just to add to that, Ben, if you look at what usually drives the culture, there's three aspects mainly. One is fear of what's going to happen. It can be in hospital or out of hospital. Family members usually argue that they're going to fall again or something else is going to happen to them. Same with the multidisciplinary staff thinking what can happen to them when they go home. The other aspect is they're always worried about the support. Is the primary care able to help the patient when they go home, or is there any support available from the neighbours, or the MDT staff thinking what support do they need? But you're looking at somebody who stayed in a ward who's independent before they came in after 10 days and thinking what support is needed. And the last thing which we know about is who do you call? If you're discharged from a ward, it clearly says National Discharge Guidelines says that they should have a telephone number to contact. I mean, we know that 80 to 90% of the discharges don't need further follow-up. That means if they've got the right family support structure in place, and then we've addressed most of them, that can be dealt with. So if you look at a family member who's fearful of what's going to happen, and then you explain the risks to them, and that will be a very clear structure for them, similar to the MDT staff, physiotherapists, occupational therapists, CPNs, doctors, nurses, anybody. And with the support aspect, we do know around about 50% don't need support. The other 50%, yes, we are in crisis and social care and all that. But based on that one, if you look at it, them staying in acute hospital actually deconditions them more, and they might need increased support when they didn't need before. They might go through the unwell episode in a few days, better off at home. The last thing is who to call is never addressed. And if we can address that bit to say that, yes, they're based on this ward or they're based with intermediate care and this is the person they can call. Most of the time, family members agree with what's happening and they can discuss the risk with the patients. And when we've seen with the really frail elderly, one of the biggest lessons we learned in the first part of COVID was when they were telling us to admit patients with saturations of 80, somebody below 80. We had people in the 90s and 100s with saturations of 68 and 72 refusing to go in. 4 or 5 days later, we did the DNA, the GPs were on board, but nearly 94% of them did not need hospital admission after that. Around about 6% needed it after 48 hours. So people take valuable risks. That means they do understand, as long as it's communicated to them. Doesn't matter what age it is, how frail they are, as long as they understand what exactly is the support available, how we can really allay their fears, and who to call when need be. I think if those three are addressed, I think we can help people change the culture, but that's going to take some time.
Thanks, Bharath. Arvind, you're waiting to come in? You're on mute.
I think it's a ritual. I do it in every single meeting, so I think it would be bad luck if I didn't do it. So thanks for the conversation. But my point again was to just reinforce what Ben and Bharath has already mentioned. It's about the communication and how we engage the patients and the carers, what language we use, how we frame the whole situation as we see it. And that I find is an art, comes, dare I say, with some experience of having gotten it wrong before. And also it requires some time to be able to have that conversation. And also the environment sometimes dictates whether we can have the conversation or not. Certainly with COVID, the chances of you meeting up with a family proactively or, incidentally, when they come and visit the family in the afternoon, you'll walk by the ward and they will ask you a question that gets you going, and we get to understand what their expectations are. And all of that has gone down a little bit, partly driven by COVID, but partly for other reasons. I'm just wondering how we can reframe all of this. Is there a way we could sort of start getting patients and carers to look at small snippets of videos, which kind of allows us to put it out there, the risks of hospitalization, the alternatives that we do have, in the community, and also, maybe through ESTEC, maybe through virtual wards, and so on and so forth. I know it's not widely available, not consistently present in every single systems, but it is emerging out there. So can we start thinking in terms of having a series of small videos using the right lingo that we can start pushing out into the community so that they do feel secure, but there are alternatives and there are, no risk free environment, because they see hospital still as the most safest place for their loved ones. But we know that is not necessarily true. So how do you sort of go about framing the whole situation and getting people on board would be my, it's what I'm thinking right now.
And to come back on that, if I may, I think yeah, I agree. It's we're not trained brilliantly for this at all, and I've stumbled through it, and I hope I'm better at it than I was 10 years ago. But I think, yeah, and someone's put in the chat about family expectations as well. I think hugely people say, but I was at junior doctors in ED, and they'll go, but the family want them admitting, and you're going to have a conversation with the family. And it's usually, well, if it's usually a faller or someone who's unwell or a bit or the frail elder, it's just a gradual decline in function. They get to a sort of crisis point or near to it. I'm really worried. I've been waiting for this long for something in the community. I'm worried this is going to happen. And it's a conversation. You say, okay, I could admit them tonight, but they go home tomorrow. Then actually, what happens if they fall tomorrow night? We know on there. And it's about an honest conversation. The only way to get to a situation, if you want the guarantee that your relative will never fall in an empty house, is to have 24-hour carers, which is prohibitively expensive, or to be in a care home. And then it comes down to what do they want. I'm a falls risk. We're all falls risks. So actually less so probably than some of the frail elderly, but actually it's that conversation. If you can't eliminate that risk, and actually points about if you fall in hospital, you're more likely to fracture, you're more likely to fall. So actually it's that conversation, that honest conversation. And I hope I'm getting better at it, but I think certainly I've never had a complaint about it, and I do this quite a lot, but actually it's about actually pointing out, well, what can we offer instead? So we have a community team that will go to the home the following day and have a conversation and assess them in the home and that sort of thing. So we can I'll give you something back in terms of, rather than giving them nothing. Giving them nothing and sending them home is hard. And it's about that honest conversation of, if they come in, particularly these days, they come in, they have got a care package, they're in for 24 hours, the care package can be cancelled, then they're in for 2 weeks. So what they see as a quick overnight admission is, it's about that conversation around getting people to understand that there is no risk for these things you say, and the language is vital. The failed discharge, and what they got, failed discharge is a terrible phrase. We should get rid of it. The failed physio. Imagine being a patient told you're failed physio. It's an awful thing to say to someone. Or expectations we set. So on the walkthrough, they must be back to baseline. So I had my knee surgery 6 years ago. Really good surgeon, really good result. Still not back to baseline. Still can't run down a hill without my knee swelling up. But it's a hell of a lot better than it was. So none of us are back. So setting the expectation of back to baseline is completely wrong. It completely again. It's set the language we use in hospital, and I have my colleagues and my juniors do it. They will actually talk about. So they say to people, they go, "I'm not happy for you to go home," and I'm talking about my happiness about whether a patient goes home. We hear it a lot. I'm not happy to discharge that patient. My happiness is actually being talked about with the patient rather than a patient. I might be really worried about them going home, but it's their choice. And actually, the language you use absolutely is so crucial in this. And it's when you start to look into the language, you look at what we're talking about ourselves there. We're not talking about the patient at all. And we need to teach this better to our juniors and to our seniors, and it's hard, I think.
Thanks, Ben. I remember a little old lady in my ED in Leeds, and when I was much more junior, explaining to me that she wasn't there to make me happy, and she decided very clearly that she was going home. So if we just move on a little bit here, how do you think that the advent of discharge to assess has affected the approach or the views about risk within the MDT and also with patients and families?
I think it's really positive step. The two things which we find very clear is the conversation is between the carers and the staff, but also they keep forgetting about the middleman, which is the patient themselves. So when we shift it across to the patient and they say that, I mean, as exactly like Ben said, if you had a fall and you come in, you actually don't mobilize an acute hospital. You actually mobilize less than you would have done at home before. And then your same risk of falls exist at home, but it becomes higher over here. The difficult aspect for people is to get the family along after the patients have stayed for a short period of time or a long period of time. That's where the discharge to assess helps out quite a bit. So when we look at what the outcomes are in an MDT meeting, especially for complex cases as well, the patients still want the same thing. They just want to go home and do the same what they were doing in the hospital, which means they were 95% of the time sitting in the chair. So when we agree to that, it's quite really distressing for family members to listen to what the families, what the the loved ones are saying that, yes, I don't do much here, so why shouldn't I do the same at home? So that conversation helped us out to say that these patients don't need to stay in an acute hospital, developing or increasing the risks of all the other things which happen here. So it's a positive step for conversations, especially.
And to come in on something, I think there's the thing as well. We need to get a lot better at that. And we did a recent award audit of our patients, and as a trust, my own trust, we do a bit of it, but not enough of discharge to assess. And one of them was quite distressing. We looked through his patient's notes, and he was a frail old person who'd been in for several weeks, and he's clearly with a lot of comorbidities, and was independent in his own home with a couple of carers a day. And looking through his notes, he's had a fluctuation with the team. He had a fluctuation of windows where he's well enough to go home. And he would get to what? So he's actually obviously normal. His blood's settled. Then you get another infection, or he became more confused, and he got a bit delirious. And over about 3 or 4 weeks in the same situation, and he's obviously deconditioned this time. And in the notes that the therapist had written, and they'd actually written in the notes that when the patient was in his lucid intervals, he was begging them to be discharged. And they've actually written in the notes, I would rather go home in a wheelchair than stay here. And of course, after that, he then got pneumonia. When we did the audit, he was back on oxygen, back being treated. And if we wait for care packages and people to be better, we often miss these windows in the frail elderly to get them home, unless you do something like discharge to assess, where you go, we're going to go today, because he was only ever well enough to go home 3 or 4 times in that 3 or 4 weeks for 24, 48 hours, and something then would happen. I'm certain the hospital environment plays with sort of had mild dementia, but had a wife at home with him, and he never got that window. He never got to that place. And it was his phrase of, I'd rather be in a wheelchair than be here, was really pertinent. And I think the other thing, to pick up a slightly different point around things we haven't talked with risk around, it's the risk to our decision making on other patients. And where we are with a lot of hospitals at the moment is, if an ED doctor admits someone who doesn't need admitting, or someone on a ward stays longer than they need to stay when they're better, then at the moment, because of the crisis we're in with ambulance things, probably up to 4 people are being harmed or at risk of harm because of that. There's the person in hospital who didn't need to be there because they've been admitted or kept in. They're at risk of deterioration and non-scopal infection. There's the person in the ED who's not in that bed because they're waiting in the ED for prolonged periods. We know ED mortality goes up for longer, and it's just a terrible patient experience. There's people being held outside ambulances in hospital who are not getting the care they want, and they're getting stiffer and less likely to get better or be dischargeable because they're stuck in the back of an ambulance. And the worst patient in the whole scenario is the patient stuck at home waiting for ambulances. And we've had people at home at the moment who have definitely deteriorated, and some have possibly died waiting for ambulances, where ambulances were stuck outside. So when we make a decision about one patient as a clinician, or the conversation we have with them, if we don't get this right, we're not just putting that patient at risk, we're actually putting 2, 3, 4 patients at risk at the same time, and we are responsible for that. We often don't see that, but we are responsible for all of the outcomes of our decisions, not just for that patient. So actually, it's the cumulative effect of these decisions is greater than the patient in front of us, and that's a hard thing as a clinician to get your head round. If you can get your head round that most of the risk sits with the patient, you can give it to them. And if I don't get this person who's coming in or keep them out of hospital as quick as we can, it's not just one patient that's getting detrimental care, it's more than one, and I'm responsible for that. So actually, in many ways, it's quite liberating as a clinician to see the patient holds the risk, and it was for me anyway, but also that if I don't have this difficult conversation, which you might with the family, I'm putting 3 or 4 people at risk, and that's even worse. But that's another thing that's hard for us to get around our heads, but actually genuinely believe that to be the case. And that's where we really move forward, is starting to see the implication of our decisions, not on one patient, but on several.
I think on that note as well, if you look at pathway 1, I mean, locally we got some data which shows that most of the packages with health and social care are discontinued after 65% are discontinued within 48 hours. And if you look at that data, nearly 80% of them, the patient said they don't want anymore, even though they've stayed in the hospital, waited for a pathway 1 health and social care support. And when you look at after 72 hours, nearly 70% of them did not need further care. So we don't know whether it's a culture thing or is it a safety thing or who's taking the risks. When the patient is at home, they seem to not want anybody to come and help them. They can go back to their independence. I think we need to think they're completely 2 different places, hospital and home. Giving the patient the choice and explaining the risks might be we might be able to move more patients on pathway zeros rather than pathway 1 when we're discharging nearly 70% from our pathway 1s within 3 days. So I don't know where we need to change the culture. Is it our thinking, our risk, or is it our communication?
Sorry, Kevin, I think one thing to come back a little bit on the thinking around risk is another thing which we often don't talk about, is that we often worry about where a patient might go home, fall, injure themselves or die. If you, and Bharath will know this better than me, the geriatrician perhaps, if you ask most frail old people, what do you worry most about? They're not worried about death. They all know death's coming. When you get to that age in life, they really worry about loss of independence. So actually, we have a system and process, and as Kevin said earlier about this safety culture, where we're worried about safe and someone not getting worse or not dying or injuring themselves, when actually what matters to them is, I want to stay in my own home. I want to see my dog. I want to see my family, especially at the moment when people can't have relatives visit so much. I want to spend time. If you're 80 odd, you've got 1,000 days left to live. How many days would you choose to spend in hospital, away from your family, away from your relatives? And actually knowing every day you spend in hospital, the chance of you going home probably deteriorates a little bit. And if nothing else, the number of days you've got at home left in your life are going down day by day. So when you look at it like that, what do they fear? We fear them getting worse. They fear loss of independence. And our job is not to do what we're worried about, it's to do what they're worried about. And again, it's a mindset shift, but it's like asking our patients what matters to them. But I'm sure, Bharath, you know more about this than I do as a community geriatrician.
Yeah, the first thing is nobody wants to go into residential nursing home. I mean, even if they've been waiting for a care package for increasing it to 4 times a day from 3 times a day, they waited for social care. And then they get admitted, they say, no, they want to go back with 3. So it's impossible to convince somebody to go to residential nursing home unless a very small percentage of them have got everything done. I think people forget if there is 4 times a day care package, there's usually 6 times a day or 10 times a day family members are helping them out as well. And if they say the family can't cope, when you take a good history from them, you realize they've actually got 10 times a day care, not 4 times a day care. And those are the ones which I think the family can't do any more than what they're doing, and those are the only ones who'll agree to go to a 24-hour supervision or a care home. And those come up really clearly in MDT meetings when we ask how much help do they get, and we're really shocked and surprised that the family have helped them for so many and so long with making their lives more difficult during COVID as well.
So just linking into the MDT comments there, Bharath, we've talked as we've gone through this about different people's perceptions of risk, and whilst we I think have been at pains to discuss that, the ultimate position, it's the patient who holds the risk, but there are still a lot of people who have different perceptions about different risks and how they should be balanced. How can an MDT work most effectively to make sure that those risks are balanced and you come to a decision that everybody's comfortable with, versus at the other end of the spectrum, passing the responsibility on entirely to one group of professionals to make the discharge decision?
I think geriatric medicine helps us out that it's mostly MDT working. The biggest aspect about that is if we focus on the basics, that means we only focus on the activities of daily living, medication and meals, the rest of them follows through. Most of the time when we get complex discharges, those are based on that one mainly. Somebody wants to improve their mobility much more than what they are. It's rarely physically possible for them. I mean, you've got sarcopenia, so convincing the therapy team along with the other people and then the care package there as well to say that yes, they around about 30% improve much more than they would have done in a hospital. Home setting, taking away contact with family members, that kind of low mood and them being in the hospital, all that is taken away when they go home. The bit which is much more clear now is with the discharge to assess processes, we get MDT conversations, which also the criteria to reside, and then they've reached the end stage or progression. We don't go to talk about back to baseline. We can say that where can the journey of the patient go next? It doesn't need to be all solved in one place. It doesn't need to be in the acute frailty unit. It doesn't need to be in the acute geriatrics, in the short take ward, or it doesn't need to be in the geriatric ward or in the community rehabilitation or stroke unit. We need to think about if the patient has achieved such a thing, why can't the rehabilitation or enablement continue at home if necessary? but also patients were doing it like without any help before. So why should we take away that independence from them? One of the things I really talk about is the patient who had a home visit, and then the patient showed them how they've been doing the stairs for the last 28 years. He's a 92-year-old gentleman. He sits on the stairs and goes up and comes down. He said, if I walk, I'll fall. So that was considered as a risk. So as a MDT, we can sign it off together, saying that yes, it should be a safeguarding issue later on if an ambulance says that. But if as an MDT discussed and the patient's family and the patient has agreed, it's a risk together with the patient. The patient knows what's wrong. So I think that conversation shift is happening, but there is no individual AHP or a doctor or a nurse who's going to take responsibility. It's usually the family members also don't take responsibility. It's the risk the patient owns. And if we can allay the risks and give them the help of how do you live independently based on ADLs, meals and medication, I think everything else falls into place. The equipment and all that is a specialty. That means occupational therapists will look into it. Mobility aids, those are things. That's when then the members of the team come into their own, and then they put in the different measures which can happen, but it can happen at home as well. So the conversation should be taken from the patient himself first, and then we can add to that.
And just one thing to add to that, I think around it, I've had a lot of conversations with the trust solicitor about this, and I've actually spoke to the MPS about this as well out of interest. And they also the same thing. They say, as long as you have documented your decision making, and that brand model is a good way of doing what the benefits, what the risks, what the alternatives, what we do, and you document it, they're really not bothered what decision you make if it's in the patient's interest. The decision is made in the patient's interest, ideally with the patient's consent. And actually, if you document the problem, the trust solicitors are really not phased. If a patient goes home and they do go home and they chose to go home and they fall and break their hip, people who are medical legal stuff, trust solicitors, they say, I want you to do what's right for the patient as long as you document the conversation. And all we've got to do, in elective care, again, we're very good at doing that. In emergency care, we're not. It doesn't have to be a consent form, but it can just be on the benefit risk. Patient understands the risks of falls, whatever, or risk of deterioration or risk of whatever. They'd rather go home, and that's fine. As long as you documented that, trust solicitors are very happy with that. So actually, borrow from elective care again. Document the conversation. Once you've documented it, I think it and again, we always just retrain ourselves a little bit with this. We've done it very well with elective care now, and it's about how we do that in urgent care.
Okay, so Robert, got your hand up? You wanted to come in with a comment?
Yeah, hi. Is it okay if I just ask a quick question? Because there's a lot I've taken away from this. In particular, the brand model is really interesting and something I'm going to look into further. I work at Kingston Hospital, and running a program I've worked to look at the kind of pathways and flow on the ward. So this is all really crucial stuff. One question I just wanted to ask is, we've been focusing a lot on criteria to reside over the past few months. It's been top of the agenda to try and make sure that's recorded well on the wards and used and then reported. And NHS England and Improvement ask us to report that regularly, and the incident control centres look at that criteria to reside and use that to measure the acuity in the hospital. How do we move away from what's quite a binary measure, you either have criteria to reside or you don't, to actually a model where we look at risk in a more holistic way? Because it's hard to measure and hard to record in an MDT discussion and also on an electronic patient record that then gets fed into reporting. So is there any examples or ideas you've got for how we can make that kind of easier to note down and then feedback from an MDT perspective?
I think we got somebody who has made a comment already over here. I think it's Dr. Poole, about having help of pull-out model. I mean, what we see is some patients might still have the news or national early warning score, which is high. The variance might be different, but knowing what can be done out in the community, how we can support them is important as well. Otherwise, as you rightly said, it becomes another tick box to say that they meet criteria to decide, and what do we do next? The conversation did not happen after that. That means the minute you had the data collection saying that this patient does not meet criteria, who takes up that next conversation straight away after the board rounds? And that's where we see the lack of continuity of care. That means, yes, we made the right decision that they don't need to stay there, but nobody's taken the next step of a senior decision maker to say that, what does this patient actually need? Or the patient's not mobilizing, but hold on, they've been through A&E to short stay ward, and then they come to geriatric ward. That's 3 days of 3 different places. They don't know the place. So, but at home, they've been walking the dog outside in the garden. So nobody had that conversation. And that's where I think it helps us to focus on what needs to be done, but trying to get that next step into an audit of to say that who took the steps of what kind of risks are there, that'll help. We've done it in a short 5-day kind of discharge pathway process locally in one of the community hospitals, but because of COVID and out of 6 doctors, we got 2 left now, so we couldn't continue it further. So trying to say that within the first 3 days, what is their capacity, what is the need, what's the discharge? We can make it into a follow-up audit or follow-up process, including the first step is who's going to take up the conversation with that patient who does not meet criteria to reside. I don't think that happens now, and if that happens, I think you'll start looking at a little bit better flow, but also the risk is gone for the patient completely. You don't need to make them stay to increase the risk in hospital. If they go home, the risk is owned by the patient, but actually there's less risk at home for these patients in their own home.
I think just as a brief, ask the patients time and time again, and I see this in EG of my juniors, and they want to admit someone who's clearly not very unwell. I said, so what's the patient want? And 90% of the time they go, I don't know. Not ask them. And actually to ask your wander around one of your wards, if you want to test it, if you're doing incredibly, ask how many patients have been, who are not obviously confused, ask how many patients have been asked what they want and whether they want to be in hospital, or they've been offered an alternative to being in hospital and taking that risk themselves. And I'll be very surprised if there's more than 5-10% who've actually had that conversation. We tend to prescribe treatment with emergency care much more than that. So there's the other analogy you can use in these things, because staff are often really proud of their hospitals, and we're really proud of our hospital. We want them to be here. We have good food and we do good care and we do all those things. And to understand what for staff and to understand why it's not great being, if you're not sick, well, it's not great to be in hospital. So the analogy you give is you go on holiday, a nice holiday, you stay in a nice hotel and you have a great time and you come home. How good does it feel to get into your own bed? Right. TripAdvisor at the hospital. I share a room with 4 people that I don't know. They keep turning the lights on, nothing nice. Sometimes someone shouts. They move me 3 times in my room without asking me. They feed me food that it's nice enough, but it's not what I choose to eat at a time. I didn't choose to do it. Bathroom. If you're lucky, you get your own room. If you're fairly unlucky, you share a room with 4 people you don't know. If you're really unlucky, you poo on a paper pan behind a curtain. Everyone's listening to you. So TripAdvisor. It's going to be a one. So, and I emphasise the point. It's important for the staff, and we laugh about it. It actually, if you had 1,000 days left to live, how many of those days would you choose to spend in the 1-star TripAdvisor hotel? And no matter how proud of them we are, and we should be proud of our hospitals, and they're the right things and all that sort of thing, it's still rubbish, if nothing else. And never mind they can't see your relatives, can't see your pets, can't see your thing, can't sit in your garden in the sunshine and do whatever. But yeah, it's just another. When staff get anxious about this, we provide really good care. It's a nice environment. It's a good reflection back. It's a lovely environment for a hospital, but it's a rubbish environment for life. And it's just another way of reflecting that back, of making ourselves as clinicians realise if there's no clinical risk, just the general rubbishness of being in hospital if you don't need to be there, or what choice would you make? It's usually not to stay.
The other bit which people forget about as well is that when you don't ask the patients when they're ready to go home or they don't meet criteria, nearly 70% of them have got informal networks of help at home. And that's what they've been doing for the last 10, 15 years. And we're trying to prescribe 100% of pathway 1 for them, which is a bit unfair when they've been living independently before and nobody asked them that question. And when we look at the notes as well, even if it's a CGA, sometimes that's not really clear, because within the first 2 days, if somebody had asked them who's there to help you out, because you do know within the first 48 hours whether the patient's going to be discharged, stroke or IV fluids, IV antibiotics, AKIs, anything else. If we can plan that element first and then do the criteria, I think you're on to a winner, but that's where most of the audits fall through.
Yeah, that's really helpful. And at Kingston, we're looking at creating a family liaison role on the ward where they can have those conversations early on to see what sort of support is available for every patient. And I think, just to finish off my point, is that we often get to a professional gift sort of model where we talk about what can we offer the patient. So what can we do to support this patient, rather than what does the patient want us to help them with. And so, yeah, it's been really helpful. Thank you for your comments.
Thank you. So The last area that I just want to pick up on is about the view of staff within hospital over prescribing care needs, and how, and we know that discharge to assess models can significantly mitigate against that. How much do you think that is based, or the overprescription of care, how much of that is based on an erroneous assessment of the risk that the patient will face at home?
We see that quite often, Kevin, because the biggest aspect we see is we are responsible if they fall. We are responsible for this. But then the patient can do what they want at home. They can go and swing around the Zimmer frame and beat each other up with it, but nobody says that. And who's going to be? So I think having that discussion as to say what they were doing before, and then following that one to say that what's the best available and what can be achieved at home. Most of the patients want to go home. They don't want to stay here. And then also they've been furniture walking. But if you say that we can give them some support at home and see what happens, they usually take up that offer. The other bit which Ben really covered was about the trust solicitors. Most of the time, if it's documented and the patient understands the risks, that is the patient's risk. It's not anybody else's risk. And the patient also knows that, the most classic example is they are going to fall again, and that we hear it all the time. But our AHP support, if that's where we get into trouble with sometimes, is that we don't support the AHPs as well to say that, yes, the patient can mobilize. We do a timed up and go test on the ward with them. We know that they need some help, but that might be completely different at home. They don't have 5 or 6 meters continuous to walk about. They might be walking with furniture already. Even if we give them equipment, they might not use it at home. So those needs to be considered as well.
Ben, have you anything you want to add, or shall I give you my final challenge?
I've got one very quick thing then. I think about how we change culture and things is around what we measure. So if you measure negative things, you get negative outcomes. If you're on a ward, you only measure falls, you measure infection control. So we used to have day rooms, hospitals walking around in day room. Now infection control, we've stopped that. I understand why, and probably good things, but actually that transition of moving around, walking to the day room to eat your dinner around maybe has gone. And we measure falls. If you measure negative things, you get negative behaviour. So if you measure falls and falls are penalised, and actually at my own hospital quite a few years ago, we had a target there will be no inpatient falls, which is one, preposterous, but two, wards were managed really negatively. This is several years ago on that, when actually the behaviours, falls are the worst possible thing, so no one mobilises. The simplest way of doing that is to do that. So actually, which ironically probably increases the falls risk, but staff felt so. So if you measure, but if you measure falls and measure balance measures like mobilisation rates, then actually, if you measure discharge and then the return readmissions, but also measure length of stay, if you measure a balancing measure all the time, then actually you start to get balanced behaviour. If you only ever measure negative things, you're probably only going to get negative behaviour.
Okay, thanks. So my final challenge is for each of you to briefly give a single take-home message to the audience about what your advice would be about changing the culture to make sure you have a sensible balance of risks.
For me, I usually bring the MDT into the conversation about discharge straight away. So if the patient has met the criteria, doesn't meet criteria to decide, the MDT is with us when we make that decision, and the patient tells us what they want. Majority of the time, it seems to be that they just need to allay their fears of what was the reason why they came in, what was the support they have, and who they can call. And that's what I based my initial conversation on, those 3 things, and seemed to be that if a junior doctor addresses those as well, it seems to be much easier for senior decision makers to make that happen straight away.
And for me, I think it is it's asking your patients what matters to them, what they want, what they prioritise, but also in that conversation using that brand model. And it's changed how I think and changed how I have conversations. And it's being honest about all the risks starts to shift your own thinking. And make you, the brand model forces you to think of alternatives, but also it forces you to have an honest conversation with the patients, and that's really our job in a nutshell, isn't it? Is to do what in the best interest of patients.
Thank you very much. So I think throughout the discussion today, I think some of the key messages given me is about, you know, discharge is a team game, and there's a real importance about how people role model behaviours in that, and that role modelling is about how that you can make sensible assessments of risk and explain them to the patient, because the patient's the one who is going to hold the majority of the risk, and certainly the overwhelming majority of the important risks within this. So I'd like to finish by thanking Bharath and Ben very much for their contributions. Thank everybody who's joined us for
please hold
their contributions. And just to ask people as we finish, there'll be a link that's going to come up in the chat box where you're able to give us some feedback about the webinars, and we'd be very, very grateful if you can do that. It just takes 2 or 3 minutes to do. In terms of our next webinar, the next one is on virtual wards and home monitoring. That's on Thursday the 24th of February, 12 to 1. And Crystal will send out a diary invite to everybody who's been on our webinars before, so please feel free to accept or decline as you wish. But once again, thank you very much, everybody, and we look forward to receiving your feedback.
Thank you all very much.
Thank you, everybody. Thank you, Kevin.
Thank you.
Kevin. Bye.
Thanks, Ben. Thank you.